Hello, everybody. Welcome. Today, our guest speaker is Dr. Wallace Mendelson, and he is going to be speaking on non-prescription sleep aids and melatonin. I'm Teresa Schumard. I'm with the ASAA, American Sleep Apnea Association, and I am our community engagement person. Dr. Wallace Mendelson is currently in the clinical practice of psychiatry. He was formerly the professor of psychiatry and clinical pharmacology at the University of Chicago. At that time, he was also director of the sleep research laboratory there. He earned an MD degree from Washington University School of Medicine in St. Louis and completed a residency in psychiatry at the same institution. He has held professorships at Ohio State University and the State University of New York at Stony Brook, and he was the chief of the section of sleep studies at the National Institute of Mental Health in Bethesda, Maryland, and the director of the Sleep Disorders Center at the Cleveland Clinic. I could go on and on and on because there are so many things that Dr. Mendelson has done, but we would never have a webinar. So I just say, look him up. And Dr. Mendelson is a great friend of mine, and I'm just so proud to have you here today, Dr. Mendelson. Thank you for coming.
Well, thanks, Teresa, and thanks, Adam. I really appreciate the opportunity to work with you, and looking forward to chatting today. Today, our topic is the sleep aids that do not require a prescription, and also melatonin. So this is a little bit different topic than usually when we chat about prescription medications. First slide, please. Well, the non-prescription sleep aid market, which they call over-the-counter or OTC, is a huge market. People pay about $400 million every year in the U.S. for OTC sleep aids. And the question is, are they getting their money's worth? Now, the most common sleep aid are antihistamines, and it's usually one called diphenhydramine. There's also one called doxylamine that's less commonly used. Now, one thing about non-prescription agents, people sort of think, well, if you don't need a prescription for it, it must be milder and safer. I'm here today to tell you that I don't really believe that that's true. Next slide. Okay. So let's talk about diphenhydramine. It was first marketed, I guess go back one if you would. Yeah, right there. It was first marketed in the 1940s. It's still around. It's used for a variety of things, mostly allergies, inflammation, movement disorders, for nausea, a bunch of other things. And it's sold under a variety of brand names. Diphenhydramine is also combined with the painkiller acetaminophen in what they call the PM drugs. It's been noted since day one that it causes drowsiness in the daytime, and so that led to the idea that, well, if it makes you drowsy in the daytime, maybe it would be good for sleep. Next slide. It actually turns out that that's not really true. The studies of diphenhydramine for sleep have been very mixed, and we're going to talk about that in a moment. But first, I want to address the question, just because you buy it over the counter, does that mean it's safe? And the message here is that, like all drugs, it has a variety of side effects. It causes sleepiness during the daytime. Interestingly, there was a recent kind of study using what they call PET scans, a kind of brain imaging, And it found that diphenhydramine was still active in the brain the next morning, even though the folks didn't believe they were sleepy. They were actually being affected very powerfully by the medication. It has what they call anticholinergic side effects. Those are things like dry mouth, blurred vision, trouble urinating. To me, the biggest worry is that there have been some studies now that suggest that long-term use can be related to cognitive impairment. And I wouldn't take it as a proven thing, but there was at least one study of over 3,000 people, and it found that folks who took diphenhydramine, for a long time, over 3 years daily, had a much greater chance of developing dementia later. It can also result in confusional states in the elderly. So it is not a benign substance. Next slide, please. Now, whether it works or not isn't even very clear. Some studies found some benefits, others have found none. One study even found that it increased your restlessness at night. And when you stop it, at least half the folks who stop it after nightly use have withdrawal sleep disturbance. Next slide, please. So the message about over-the-counter sleep aids is it's true you don't need a prescription, but the evidence that they help is really pretty slight, and they have a whole range of side effects, even though they're non-prescription drugs. Well, let's turn to our second topic, which is melatonin, because loads of folks use that for sleep. It's one study found that it's been taken by over 3 million Americans in recent years. Well, what is melatonin? It's a hormone. It's secreted by the pineal gland in the back of the brain when it's nighttime and when it's dark out. So some folks have called it the hormone of darkness. It can be purchased as a dietary supplement. So again, no prescription, although it's not considered a drug, it's considered a dietary supplement. Next slide. Well, does it work? The question is, work for what? Melatonin helps reset the body clock. So it's been found to be useful in some specialized disorders of the body clock, and that's different than just plain old chronic insomnia. And we'll get to that in a moment. But let's talk about some conditions where melatonin has been found to be useful. One is called delayed sleep phase syndrome. These are folks whose internal body clock runs a couple of hours later than most of the world. So what happens is when they try to go to bed at, let's say, 11 p.m., their body thinks it's still 8 p.m. They're wide awake. So they don't feel sleepy until maybe 2 or 3 a.m. And this situation can look like initial insomnia because you have trouble sleeping until 2 or 3 in the morning. When you do fall asleep, though, you sleep very well. And if the world allowed you to, if you could just sleep till, say, 10 in the morning, you'd feel great. The trouble is most of us have jobs and school, and so we can't sleep that way. So it becomes a sleep disorder. Another problem is called non-24-hour sleep-wake disorder. And this is a situation in which the body clock just runs on its own without reference to the rest of the world. And melatonin has been helpful in that. And finally, although the evidence isn't as good, there's some evidence that melatonin can help you get adjusted to your new sleep and waking time after traveling by jet, for long distances, east and west. Now, in these very specialized conditions, melatonin can be helpful. But in contrast to this, in regular chronic insomnia, it's not at all certain that melatonin is particularly helpful. One big review of all the papers that could be found described its benefits as unclear. Another study found that it shortened sleep time on average by 7 minutes and raised total sleep time by 8 minutes, which is far less than prescription sleeping pills. So it suggested maybe there's some role for it, but it's really not terribly effective. Next slide. Once again, it's not absolutely benign. About 20% of people who take it feel sleepy in the daytime. Less commonly, there can be dizziness and headaches, and it can interact with other medicines, including some medicines for diabetes and some blood thinning medicines and some birth control pills. So once again, melatonin, next slide please, has the kinds of effects you might expect from a drug. Now, some very specific concerns is that since it's sold as a dietary supplement, there's not as much supervision by the government over its quality of production. One study recently, they bought as many different kinds of brands of melatonin as they could find, and then they analyzed them chemically. And then when they did that, they found that the real amount of melatonin in these products was as low as 83% and as much as over 400% than what's on the label. And finally, I would just mention that in the most recent guidelines of the American Academy of Sleep Medicine, melatonin is not recommended for chronic insomnia. So next slide, please. So the bottom line then is that both in the case of melatonin and over-the-counter sleep aids, it's important to be aware that even though they don't require a prescription, they're not entirely benign substances, and you need to take that into account, especially when considering that the amount of benefit they give is pretty questionable. Well, these and other topics can be found, if you're interested in reading more about it, in a book I wrote recently called Understanding Sleeping Pills. It's available on Amazon. And with that, I'd like to say I'm open to chatting about any aspect of this you'd like to talk about.
I'd like to get us back towards the beginning of your presentation when you were talking about the different substances. Could you, or do you feel okay mentioning some of the brand names? People may not know the long names, but they might recognize a few commercial names if you know some of those.
I'll tell you the truth, I think I'm better with the chemical names than I am the brand. Okay.
Well, if they looked at the contents, then they could, on any given medication, they could look at those medicines that you bring up, the chemical names. So. Well,
if you go to a drugstore or grocery store and just look at non-prescription sleep pills, it's overwhelmingly likely that if you look at the name on the bottle, it'll say diphenhydramine, and in a few cases it'll say doxylamine, and that's true also with what they call the PM products, things for sleep and pain.
Pam Gordon, thank you very much. She says that, and now the message is gone, but she mentioned Benadryl was one of the earlier names associated with. Can we go back to that first couple of slides? Let's see. All right. Here we go. This is what Pam was just talking about, that this would be Benadryl. So that, at least, our audience can relate to that. What about the melatonin, Dr. Mendelson? Do you know if it is a good idea or a bad idea to give that to children?
Well, again, for all the reasons that I just mentioned, I think it's probably not a good idea. It can cause next day drowsiness and things of this nature. One thing that we haven't talked about and didn't get into is that melatonin has other effects on the body, which include the fancy name for it is antigonadotropic effects. That's a fancy way of saying it suppresses fertility. And the reason I mention that is that I don't know the consequences of giving it to children. I'm not sure that anybody does in terms of later, adolescence and sexual development. But I have some concern about long-term use of it in children and adolescents for that reason.
We have
Dr. Wiley, this is Adam. It looks like there's a couple of questions coming in on the chat. One from Eugenia Brooks. Are there any natural means of getting melatonin?
No, I don't think there's any dietary means of getting it. Again, it is sold as a supplement, which you can buy. The main thing about it is that to remember that it's secreted only in the dark and only at night. So one concern that a lot of folks have raised, gee, I'm kind of glad you mentioned this because this is an important point, is that getting bright light in your face in the hours of going to sleep actually can suppress melatonin secretion. And there's growing concern, especially in children and adolescents, about, using tablets and phones in bed at night. And there's been found an association with difficulty sleeping. So as if there weren't enough reasons to reduce tablet and screen time, at night in bed, here's another one, is that it may be associated with poor sleep. And the mechanism that this happens by has been attributed to decreasing melatonin secretion. Interestingly, a lot of tablets now have a nighttime feature which changes the wavelength of lights that comes out of your tablet.
Yeah,
so
we like to take credit for that because with our Sleep Health Apple Research Kit study, we feel like we turned the Apple employees onto that way early on with what was going on. So we like to think that we had something to do with them putting night shift into all their to their iOS platform.
That's a terrific thing. I hadn't realized that, but that's wonderful.
I have a follow-up question for you. If melatonin is supposed to be coming from the pineal gland, is there a risk factor or a biomarker test or a blood test or something that we could be looking at children early on to see if they're not producing this or not getting the melatonin? So then obviously that would be a red flag for maybe something else going on in their sleep.
Well, there are, I'm not sure if it's clinically available, but there are definitely research used blood tests for melatonin, which are done very commonly in research projects. There's even a way of detecting it in saliva samples. I'm not sure about the specific need of using it in children, aside from looking at their body rhythms, but yeah, such tests are available. This is kind of a specialized group, but one group of children who have terrible difficulty sleeping are institutionalized children, where they're not allowed to get out in the sunlight enough and to get enough exercise. And very often in chronic institutions, the children sleep very, very poorly. And there have been studies, they're kind of old now, saying that melatonin can help regulate sleep in that situation.
Yeah, we've got a lot of questions coming in here, so I'll let Teresa go next.
Okay, we have a question from Julie, and she says, I have taken some type of sleep aid for years. First prescriptions, then moved to melatonin for better alternative. I take it for depression because I have trouble falling asleep. Is this bad? How can I stop or wean off of sleep aids?
Well, is the concern specifically non-prescription sleep aids, or is it using all of these things?
First it was prescriptions, then she moved to melatonin for a better alternative. She takes it for depression because she has trouble falling asleep. Is this bad? How can I stop or wean off the sleep aid? So she's using the melatonin as an alternative for the depression.
Right, and she wants to wean off of that.
Got it. Well, Julie, I can't address your individual care specifically, but I can talk to you about the general issues that are involved. One is, again, the evidence isn't absolutely firm, but some people feel that melatonin can actually contribute to depression. So that's something that you may want to speak with your doctor about.
I like to tell people, Dr. Wally, that when you can't make sense of what meds you're on, sometimes going back to the beginning and starting over and ruling out one variable at a time is sometimes helpful. I've learned, especially when you're cognitively impaired and sleep deprived over a long time. So.
Well, I couldn't agree with you more, Adam. And so I would really sort of express two thoughts. By the way, in my book, I have a chapter called "When the Sleeping Pill Isn't Working." And the main point is exactly the one that you just raised, that you should use if you're unhappy with the sleep treatment, you should use it as an opportunity to go back and check everything out. And there's a number of things to check out. One would be, are there other sleep disorders in there that we may be missing? So for instance, as I'm sure Adam and Teresa could tell you at long length, sleep apnea is associated with disturbed sleep, and you would want to make sure that sleep apnea hasn't been overlooked. Periodic leg movements of sleep are another one. So
and that brings us to a good question from Becky Davis. She asked, has there been a study on how these meds affect sleep apnea? Is there something that you would point to, or is there some sort of metadata analysis, or is the literature sparse on this, or because the supplements are so varied that we don't really have a good understanding? Sorry to ask questions at once.
That's a great question. I don't really know of good information on diphenhydramine or melatonin specifically on respiration. The melatonin receptor agonist, Melatonin, which is a prescription sleeping pill, is one of the few sleeping pills that does not seem to have much of an effect on respiration. So it's one of the few that one should think about if one has mild or moderate sleep apnea and is considering a prescription sleeping pill. The best advice, of course, if you have sleep apnea, is not to use any sleeping pill. But I do mention that for Melatonin, the others, if there is respiratory difficulty, the prescription agents, which are probably less likely to cause these kinds of difficulties, are Melatonin, doxepin, and among the so-called Z drugs, the newer prescription sleeping pills, probably Zalopon. So yes, one should be very conscious of the concern about respiratory depression if you have sleep apnea. My own choice is not to use sleeping pills at all in that situation. I realize that's not always practical, and to consider non-drug treatments for insomnia. And as we were talking in our last broadcast, probably the best non-drug treatment for insomnia is called cognitive behavioral therapy, or CBTI. It's equally effective as sleeping pills in mild and moderate insomnia, and you don't have to worry about respiratory depressants.
We're at the half-hour mark, Dr. Wally, and I just want to do a little housekeeping. So to anybody that wants to ask any questions, please feel free to either type them in the question and answer box on the Zoom platform, or if you like, raise your hand and we can unmute you as well. You could also ask questions via the Facebook Live portal. So happy to continue this conversation. I just wanted to talk about something in relation to the Benadryl. I can remember over 10 years ago, before I ever started even treating my apnea, how much Benadryl I was eating because my allergies were so bad. Why were my allergies so bad? My immune system was compromised. And that Benadryl was helping me, yes, get to sleep, but it was also opening up my airway so that I could breathe at night in some ways. Now, was it suppressing my sleep and my breathing? I'm sure it was. So it was very much a double-edged sword. One of our panelists, one of our leading patients, Joelle DeBrow's got a question here. She says, I've used 10 milligrams of melatonin to help keep me sleeping until it stops working, so I cut back to 5. It still leaves me with a lingering hangover. Why is that, Dr. Wally?
Well, I don't know if anybody fully understands the reasons behind it, but again, about 20% of folks who take melatonin for sleep definitely have sleepiness and hangover feelings the next day. Again, I can't address you as an individual, but just talking in general, you should know that the amount of melatonin that you can take as a pill that reproduces about what is the normal blood level at night is about 1 milligram. So things above 1 or above 3 milligrams are boosting melatonin beyond the normal physiologic range.
Are they seeing, and I think I heard something mentioned at the NIH Women in Sleep meeting yesterday, are they seeing issues in regards to cancer and melatonin and lack of melatonin in cancer patients? Or did I dream?
That one I don't know about. I better take a pass on that one. That sounds like it's a cutting edge thing.
A lot of the information that was coming out of the Women in Sleep meeting was cutting edge. It was an amazing meeting. I hope that you all were able to catch that, some of you. And if you weren't, you should, in a few days, it'll be posted so you could watch it, at least parts of it. But, well, Dr. Wally, let's see, do we have any more questions like on Facebook coming from there? Or I'm glad to see such a high number of you here today live. We usually get a lot of people watching it on the replay, which is nice. We'll be on YouTube usually about, within 24 hours after we're live. So that's good.
Yeah, I'm thinking about all the Benadryl and all the over-the-counter that's being sold, how we could be screening all these people or all these parents with children with children with allergies.
Yeah.
I really think that's probably an untapped place for us to look from a public health standpoint as an early recognition or early red flag for what's going on with children with their immune system and sleep disorder breathing and a lot of other stuff. Because it's easy to get into that pattern. I can remember doing it as a young adult, and I can remember doing it as a parent, thinking, oh, this is what you give your child when they're having allergies. But you only want to give an antihistamine when you have to give an antihistamine. Not I'd imagine you build up a tolerance to it and it loses its effect over time.
Well, we think so. I guess the good news of that is, in terms of taking it in the daytime for allergies, you get tolerance for the daytime sleepiness usually in a few days. In terms of taking it at night, I guess the research just really hasn't been done. But as far as we know, you have ongoing sleepiness, and it can be a real issue in terms of safety and comfort.
It'd be interesting to look at all the Walgreens, the CVS's, and all the other big pharmacies, big box pharmacies, and see how much Benadryl is being really sold out of there.
Absolutely.
by the hour, by the minute, by the day, and at what time of year, I can imagine it's very, very telling.
Absolutely.
Well, I think that we're going to close up for today, and thank you so much for being here, Dr. Wally, and we look forward to hearing from you again soon. We're going to have one of Dr. Wally's articles on our website shortly, so be sure and look for that. And he's just so wonderful to share his knowledge with us, and we're so grateful that you were able to help us out, Doctor. It's been so much fun connecting with you again after all these years.
Well, thanks so much, Teresa and Adam. I'm really enjoying working with you all, and think that the work that you're doing is a wonderful thing. Thanks again.
Thank you for helping us educate our audience and helping us translate this out to the masses in English so that people could actually understand it. Some days I make sense, sometimes I don't. So hopefully today was one of those good days.
I think it was.
Okay, bye everybody.
Bye all, have a good day.
Bye, thanks, you again.